Hello and welcome to Pulse, your podcast delving into all things health, innovation, digital and data. Proudly brought to you by Pulse IT News. I'm your host, Louise Schaper.
And I'm your co-host, George Margelis.
Happy New Year, George.
Happy New Year to you, Louise, and to all our listeners, and looking forward to an interesting and exciting 2025.
Well, it's already started as an interesting year. There's so much been going on globally in, things that are outside the scope of this podcast, but it's hard to take your eye off them.
That's true. I mean, I was just this morning watching the inauguration of the new president, and hearing about a ceasefire in the Middle East. Everywhere you look, AI is everywhere. So I guess that's pretty much like last year. But yeah, it's going to be a brave new world, and we're going to see what happens with the major reforms around the world in politics, in healthcare, and whether Robert F. Kennedy's nematode does have its main effect on people.
I'm sure we will be covering the US a bit more this year than we have in other years.
Absolutely.
And so what have you been up to since I've seen you since our fireworks spectacular on New Year's Eve, thanks to AI?
So first of all, that was well done. That was really impressive. It caught a lot of people's attention. And yes, it did bring out my best side. Look, it's been a great Christmas, New Year break. It's been fun, I got to spoil my new granddaughter with things that she has absolutely no use for, but I thought were really cool. I caught up with our extended family, so all together. And that was actually a little bit more complicated than usual this year because the local Greek newspaper, a thing called the Greek Herald, published a story about a presentation I did back in November at the New South Wales Smart Sensor Network Aging Forum. The article got published between Christmas and New Year for some bizarre reason. And so I had to try and explain to my family yet again what I do. And of course, with an aging family, I had to explain to them that, yes, whilst we are working on solutions, we haven't quite solved all the problems of aging yet. So no, I don't have the magic device that's going to make them young again. But hey, we are working on it.
One of the things that we're excited to bring you Pulse Potties this year is a little new segment that we're introducing at the end of the show, which are recommendations from George and I, which sometimes they're going to be digital health related, but they might not always be.
Absolutely.
All right, shall we get into our hot topics, George?
Let's go for it, yep.
Well, let's kickstart with everyone's favourite topic, AI. Now, don't switch your dial yet. We've got new stuff to talk about AI. Now, we've talked before on the pod about the real-life use cases for AI in the health and biomedical sciences, not just in the practice of healthcare. Well, there's a few stories that have broken over the summer, which shows how those, real-life use cases are already working to advance medical knowledge and save lives. So there's a few stories here. Firstly, Nature magazine had a great feature on the use of AI to forecast the evolution of viruses. So they analyse vast genetic data sets, and then AI models can predict which viral mutations are likely to thrive, potentially enabling the preemptive development of vaccines and antiviral therapies. Now, it's not fully developed yet, but once it is, that could be amazing advancement in pandemic preparedness. In another story, Cell magazine published a groundbreaking study, it was incredible, where the entire human proteome-phenome has been identified and mapped. So scientists now know the relationships between almost 3,000 plasma proteins, over 700 diseases, and nearly 1,000 health traits. Machine learning was, of course, put to good use to uncover diagnostic biomarkers and potential drug targets. So precision medicine is getting closer. And finally, in a story, now bear with me, Australia has long been home to the most deadliest spider on the planet, the funnel web. Likes to hang out in Sydney and places where George hangs out. Well, it turns out that there is a new species that has been discovered, and it's being dubbed a big boy because he's much bigger. He's about 10 centimetres wide, and his venom is even more deadlier. But fear not, because AI is on the case. AI is now also being used to design proteins for creating antivenom for spiders, snakes, and other venomous creatures. So, George, in your wanderings around Sydney in your youth and up until now, have you ever seen a funnel web?
Look, I have seen one behind a piece of glass at the zoo and at various sort of exhibitions. I'm told they're all over the backyard, but I tend to avoid the backyard because that means gardening work. So far, so good. I've managed to avoid dealing with them. But yeah, look, I think these three stories are particularly interesting and because they sort of fill in part of a bigger picture. So, you know me, I'm quite a nerdy guy. So I do read Nature and Cell magazine. And these sort of stories demonstrate that basic biomedical sciences are still growing. We tend to think that we've learned everything we need to learn, but the Cell magazine article looking at that link between plasma proteins and disease just opens up a whole new gamut of things to talk about. And for the less biologically inclined listeners, I might just give a little bit of a synopsis of why this is important. So we've seen this year, the Nobel Prize in Chemistry went to Demis Hassabis from AlphaMind for their work on AI and proteins. And even the Nobel Prize in Medicine went to the team around microRNA. We got really excited back in 2000 when Craig Venter announced they had mapped the human genome. Everyone thought, okay, that's it. We've solved precision medicine. We know what's going to happen now. And whilst it was a very important step, the gene is just a part of a process. And without the entire process going through it from beginning to end, you don't get anything happening. So DNA is the plan, the blueprint which tells the system what to produce. I tend to like to use a bit of a house building analogy here. Recently, we've discovered that some things can influence DNA. That's known as epigenetics. That's a big topic in itself. I won't go into it. But again, it basically means that whilst we may have a blueprint, the epigenome determines what part of the blueprint we actually have access to. So it'd be like building a house and sort of saying, well, we're not going to show you what the bathroom's going to look like until later.
With epigenetics, is that sort of like the cells have memory that are passed down through the generations? So I believe things like trauma can pass down, even though you yourself has not experienced that trauma.
Yep, and that was a great work done after the Second World War, where they saw that people involved during the war had different genetic expression to those who weren't exposed to those issues. The body itself determines which part of the genome is actually expressed. So you may have a gene for something, but the epigenome controls that expression, and that's really becoming an interesting part of medical care now. And as we talk about longevity, we've seen a lot of the work being done around the epigenome as the determinant of how people age successfully or not so successfully. But what happens, the DNA is being read by what the building managers, which we call the messenger RNA. They go into the nucleus, look at their DNA, take out a copy of what the blueprint needs, transport that across from the nucleus into the cytoplasm, which is pretty much the building site. They transfer that to the transfer RNA, which is, I describe as the foreman. He's the guy who takes the instructions and sits down with the actual builders, the brickies, the carpenters, the plumbers, and tells them what to do. Now, the equivalent of those builders is the ribosome. It's a complex within the cytoplasm which takes that information and turns it into proteins. Proteins are the essential building block of everything that happens in our body. So it's the equivalent of not only the structure of the house, but the plumbing, the electrical, the windows, the doors, the control mechanisms for those doors are all determined by proteins. And this is where it gets really interesting, because proteins are microscopic collections of amino acids, which we count how much protein we eat, but we don't understand the fact that that protein in our human body is what drives all of activity, from cell gateways when electrodes can come in, how our nerves work, how our brain works. The human body has over 30 trillion cells alone, not including all the cells that are part of the microbiome. So proteins are essentially the instigator, the doer of everything that happens in our body. So understanding proteins has come a long way from understanding here is a map of what a protein looks like to what a protein actually does. And you look at the work of AlphaMind, proteins just aren't a string of amino acids. The way they fold, which is affected by weak and strong nuclear forces, electrostatic forces, hydrostatic, there's all these things that influence the folding of a protein, which affect its function. So proteins are really, really important. They're not just the things we measure in our protein powders in the morning. They really, really do play a key role in determining not only our health, but the survival of the species at a large scale effect.
It's sort of a side issue, but on the topic of proteins, a lot of our listeners would have watched The Breakthrough on Netflix, because in Australia, at least, it's in the top 10, and it's a Swedish crime drama. So crime dating back a long time ago where, DNA evidence was still at nascent stage. Well, hang on, spoiler alert. So if you haven't watched it yet and you want to, just fast forward a minute. But they introduced new technology, and this show goes into the detail of genealogy, where they actually show, George, that it's not just the genes that they trace through family lines, but the protein and the protein pairs. And I also read a crime book on the holidays, and the same thing. It was genealogy. I'm like, oh, everything's about proteins in my feeds at the moment.
Yep, they're an essential component of everything that happens in our bodies. And like you said, they have enduring effects. Yeah, so the fact that we're doing a lot more work in there and using AI to understand something which is so complex that it's really hard for a single human mind to get their head around it is great. I mean, previously it took up to 3 years to determine a protein structure. Alpha Mind has shrunk that down to hours. So it's really quite an amazing transformation.
It's just incredible. And, like whether it's for antivenom, drug development, understanding the links between diseases, I mean, these things will change very quickly because now we're not relying on just really smart humans that no matter how smart you are, there's only so much you can get done in a 24-hour period. And there's a limit on the speed of human cognition compared to AI. It's something that computer does a lot faster than we do. And of course, just before Christmas as well, Google announced they've got a quantum computer. If we combine the AI, the machine learning, collecting all this data and analyzing it at the types of speed that we can now, let alone before quantum computing, we could see some really big advancements in our understanding of disease and what's needed to treat those diseases for each individual.
It's really exciting times. And like I said, we're now understanding disease process at the cellular level. Whereas beforehand, we had looked at everything from a very macro level. We gave you a drug and the rash went away. Now we know what causes the rash, why the rash went away, what cell gates within the cell are causing that rash to flare up. It's really exciting. The difference, of course, is the physiology textbook went from 200 pages in my day to 2,000 pages now. So it's, keeping up with it is a real task in itself. But you can use AI for that as well, I've noticed.
You can. Absolutely. It's fascinating stuff. So any feedback that Pulse Potties have, if you'd like us to include more stories like this, where we're looking at the science of human biology and bioscience developments in AI, we will continue to put them in the show. We do talk a lot about AI in terms of its practical application in the business of delivering healthcare. But what's important to understand, AI is not Superman or Superwoman. I just love, George, how these tech bros, they just have no shame in stating various versions of, don't worry about fixing healthcare, we've got this. I literally saw a post on LinkedIn recently, and this guy was like, don't worry, help is on the way. AI in healthcare is moving quickly, and it's going to address costs, quality of care, and population health. And I thought if only that was true. Of course, AI may not be a panacea to fixing healthcare, but man, it's going to continue to be helpful. Pulse IT wrote about research in Australia, which had a few different researchers from the University of Adelaide, Queensland University of Tech, Uni of Melbourne, Uni of Western Australia, and along with the Queen Elizabeth Hospital and Peter Mac Cancer Centre, looking at how AI is being used to identify from a mammogram, not just reading the mammogram to state, is this cancerous or not, but actually predictive. So this is a game changer, looking at what can an AI do to look at a mammogram and understand features that are in that image that could indicate a risk of developing breast cancer. And then once it does that, it's the job of clinicians to work out how to apply that information. What are your thoughts on that one, George?
Again, that particular story I found very exciting. You can always trust Aussie researchers to actually find real use cases, not these fluffy use cases, because, the success of their research is not based on the share price of the company behind them. So that's really important. Look, it's not a coincidence that companies like this focusing in on the digital parts of healthcare where the data is actually amenable to computation. So rather than thinking, we can do everything and anything. And it was an interesting article which came out just recently, and we'll probably touch on it in the next edition, is medical history taking. When AI tries to do medical history taking, it struggles. But when it's given data to actually use to compute stuff with, like it is in a mammogram, it's very successful. And this also demonstrates the need for big data sets, because if you only had 20 mammograms to base this on, it wouldn't work. But by having hundreds of thousands, if not millions of mammograms, looking for those correlations, and whilst we may not understand the physiology of it, that correlation is enough for us to give us a target to focus our research on. And I think Peter Mac and Queen Elizabeth have been famous for their high quality research in oncology. This is a real opportunity. If we can identify those at high risk a little earlier, get engaged in with them early, which comes to some about other discussions around, we can make this information available to individuals to help them make more informed healthcare decisions. This means that you need a mammogram more regularly. You need a different type of mammogram. You need an ultrasound versus a X-ray. Those sort of triggers enable people to push the envelope about how their healthcare is delivered, slightly improve things, and we'll start seeing improvements in outcomes as a result.
Yeah, it's so good. I haven't had a mammogram yet. And sorry, Mum, I have been meaning to get around to doing that, but I will. But for this to have for us to be able to harness this technology, we also need to make sure that our data capture is really good. And one of the other things that happened to me just last week, I got a letter from the Department of Health and I'm like, uh-oh, what have I done now? Anyway, and it was reminding me to go have a pap smear because I haven't had one apparently, according to their records. When you last have a pap smear, it's not a thing that women, it's not something we look forward to. It's not really something that, we get to more frequently than required. I know I had one done last year. I do not need to have another one. But clearly, the clinic that I went to did not put my results into the databases that collect these things, which actually led me to think, shit, maybe I do need to go and get another one because, they're supposed to contact you if they see anything that is something to be potentially concerned about. And I didn't get that call, but I'm like, is that because my test results just disappeared? So I decided I better go take care of my lady business and get the mammogram, do another pap smear.
Wouldn't it have been nice if they had, by legislation, required them to upload those results into your My Health records? What an interesting idea that would be. Maybe we should consider that.
Fascinating. Maybe the government could introduce some legislation on that, George.
Some legislation. Yes, I think there's a possibility there that that may solve part of that problem. Because again, and you make a really valid point. I mean, the fact that you've had a pap smear and that result is sitting in the ether, and you're a healthcare and digitally literate person who knows how to access that information. If that had been a negative result and you didn't know about it, and 3 years down the track you went in full florid cervical cancer, you'd be really upset that your result from 3 years ago was not acted upon because, hey, it was never made available to the right people. We are saying, for example, the bowel cancer screening thing is pretty good. That result ends up in My Health record. You do get your bowel cancer screening results into My Health record. You get a letter telling you that your GP has been informed of it. Those are the sort of things that drive the value of big data, not just, and this is where we need these biobank type models and just secondary use of this huge amounts of data that we collect to be part of our ethos of how we deliver care.
Oh, yeah, it should just be a given. And I mean, we hope that Albanese doesn't call the election before that legislation gets passed. If he doesn't, maybe I'll wait to I'll put it off another month or so so I can get a copy of my results myself.
And I have to admit, I've started now, voting with my feet. So we now only use labs that in our family that upload results. We've got 3 or 4 labs up the street here. We changed labs, and it's caused a bit of confusion in the beginning because you have to compare oranges to apples in the beginning. But I sort of said, look, for the kids and for the boys especially, they should have their records from now because it's going to be relevant in 20 years' time when someone says, what was your cholesterol when you were 20? Oh, I don't know. Well, hang on, here it is.
Exactly, yeah. And I've got paper records dating back because I was part of a research study when I was like 18 because I always knew I wanted to do a PhD. And so I thought if I participate in other people's research studies, then hopefully when I need participants for my studies, people would say yes. So I was hoping there'd be some sort of like research participant karma. And I was quite thin, like 17, 18 years old in my first study, and I had high cholesterol. But the good thing is now I know that that's actually just part of my, let's say, genetic makeup. I'm sure there's some proteins involved in that too, given our earlier discussion. So now I know that's my baseline. And so, whereas other people who have a much lower baseline, I've managed to keep mine stable. So that's been really useful for me to have that information. But yeah, it's not in my health record yet.
And that's a great example. There's actually research along those lines showing that stable cholesterol versus rising cholesterol is the issue. But if you didn't know what your initial cholesterol was, you would have just said, oh, number's high, start you on a statin with all its side effects and see what happens.
That's right. Oh, all good things. All right, let's move on. New hot topic here. So switching over to telehealth and virtual care now. In the US, patients and clinicians alike were pretty stressed out before Christmas, lobbying their Congress because Medicare funding for telehealth was going to run out at the end of December. Well, luckily for our US friends of the pod, Congress did act, but they've only extended the deadline to the end of March at this stage. So we will see what changes are made under a Trump presidency.
Yeah, the Americans have this flair for the dramatic, don't they? They've been doing this with telehealth since the COVID time, extending it a couple of months at a time, even though they publish many articles about how good it is. But the reality is it's been shown to be beneficial.
So, yeah, George, we'll be paying attention and what's happening because it's probably going to be quite a few healthcare related changes in the US, but certainly lessons that are coming out of any of our global jurisdictions on the value of telehealth. We want to share them on the pod. Speaking of, though, I'm going to segue to a positive telehealth story. So over in New Zealand, great news out of Christchurch, as reported by Reece Lyon at Pulse IT. A telehealth pilot, so a trial, was able to divert more than half of potential emergency department patients. And this is like a super big deal because hospital EDs pretty much the world over struggle with access block, ambulance ramping, where basically generally demand for services is much higher than supply. So great news coming out of Christchurch, and I'm sure there'll be a lot of lessons that can be applied to health systems everywhere. I read the New York Times regularly and an article that caught my attention. So I love this. An emergency doctor in the US called Helen Yu Yang penned a guest essay and it was entitled How Virtual Appointments Taught Me to Be a Better Doctor. And she said, I always thought tech-enabled conveniences would be at the expense of human connection. It turned out I was wrong. So I thought that was a beautiful sentiment and certainly helps feed the case for telehealth. Doesn't mean that it's a lesser experience depending on the circumstances. What do you think, George?
You and I have been talking about telehealth and virtual care for literally decades, haven't we?
Yeah, it was my first job.
I was working on back in the early 2000s with the telehealth solutions, and we keep on having these discussions about it's good or bad. New Zealand's a great example. It's one of those great examples of necessity being the mother of invention. We've seen the significant cuts in their healthcare budgets as a result of the changes in government and what's happening there. So again, that forces people to think of out-of-the-box solutions. And 20 years after its introduction, you would think telehealth is no longer an out-of-the-box solution, but implementation at scale still remains a challenge. And here they demonstrated that if you can cut the number of people turning up to your ED by half, that means those that are there will get through a lot quicker. And I don't know about you, but in New South Wales, we're now talking about 16 to 20 hour waiting periods for people to get through ED. So the emergency part and 20 hours waiting is not a great combination. So I think it's really important that examples of this being brought through. We saw it go from no one thought it was a good idea before COVID to becoming the de facto standard. What we didn't do well in COVID is continue to develop it. So we let telephone be the defining standard for telehealth. When looking at Helen Yuang's article, when you add extra functionality to it, the ability to see someone over a video. And yeah, the previous generations think that video communication is not human contact. My kids do 75 to 80% of their connections via video online. So the fact is you develop methods and tools to utilize the tools you have available. And a good video with the ability to also capture some vital signs, to capture historical information, because the best way to get your smartwatch data to your doctor is uploaded to them so it's waiting on their desktop when they're doing their telehealth conversation. I think we just need to start thinking about this. This is not an alternative. This is just another way of delivering the same service was always delivered. And clinicians and consumers are smart enough to realize when it's right for them and when it's not right for them. Like I said, if you're having crushing central chest pain radiating down your left arm, you don't call up a telehealth consult. I think most people have got that now.
Unless you're in the bush.
I mean, you have no option. Exactly, yeah.
That's right.
Yeah, so I think we need to think more about how we build it into the system and not penalize it, not make it a lower rebate or a more complicated rebate or, limited to X uses per year or whatever, but put in a governance model so those people who are trying to abuse the system can get caught out and name and shame them. And this is the problem we've had with a lot of the medical reforms. They bring in something and someone works out, here's a way to make a quick buck out of this. And of course, the whole system is tarnished with a few bad actors who abuse the system for financial gain.
So congratulations, Christchurch. And I want to see more reporting on the lessons learned. And, we can talk about them on the pod and share them with our global audience. It's like, well, what are we learning here? How can we do things better? What didn't work so well? These are really important things. And we'll feature some case studies throughout the year on the pod as well, where we look into some of these things. Okay, well, our final hot topic is consumer engagement. Now, this is a topic we are big fans of on Pulse, empowering patients and consumers. Well, if you're not sure how to go about doing that, Marlene Winfield and Cambridge University in the UK have published an action plan for the digital patient. I'll put a link to it in the show notes. The guide provides a series of actions under 8 headings to create a framework that ensures preparing patients for the digital future happens in tandem with preparing the workforce. And many of the 8 items focus on capacity building by not just the patients or the consumers themselves, but by the actual healthcare system, the workforce, as well as consumers. And then also on the topic of consumer engagement, and also in the UK, just before Christmas, the British Medical Journal published a study pointing to the inherent waste in direct-to-consumer tests, which of course piqued my interest. Now, the authors of that study point out that sales of these tests have surged, and this is US figures, but $15 million in revenue in 2010. This would be US dollars. So, and then fast forward to 2022, fast forward 12 years, and it's gone from 15 million to 1.15 billion. And that's just in the US alone. And if you think you haven't used a direct-to-consumer test, you probably have. We're talking tests for things like COVID-19. I don't think I know many people who haven't done one of those home tests. Genetic testing, prostate health checks, food sensitivity. I was talking to someone recently in the break who was complaining that her husband, who's clearly allergic to some stuff, got one of these food sensitivity kits in the mail and decided to do it himself instead of actually going to see a GP and then a dermatologist. However, no regulatory framework exists to govern the appropriate use of many of these tests. Now, George, of course, we are big fans of patient choice and accessibility, but what do you think we need here to ensure quality and necessity?
Well, first of all, reflecting on the British study, thank you, Britain. You do great studies. And this document is a particularly interesting one because the reality is, as we get on, digital patients are going to become a bigger and bigger part of our system. We still have some people who are resistant using digital technology, but the reality is my generation will all go see their doctor with their digital phones in their pocket. So enabling the system, and it has to be both the consumer and the clinician, because this concept of a digital partnership in health is really critical. I think focus points they had in their document is great. I recommend it to every healthcare system to start thinking about this is what your patient in the future is going to be looking like. This is how you need to prepare for it. And yes, we have My Health Record. Yes, we're now starting to see the rise of some patient portals through some of the systems, but that total integration of the experience for both the consumer and the clinician. And the reality is a digital patient can actually make the experience better for the clinician as well, because you're working off the same page of data. You're involved in shared decision-making. It's really an enabling tool. So we really need to think about it. And we've had good old e-patient Dave when we were speaking with Alain from WHO. We can see that having enabled consumers who understand this, and not just here's your results, away you go, but understand this part includes health literacy and digital literacy. But direct-to-consumer tests are interesting. I mean, there is value in them. You need to think about what drives people to take these consumer tests. Well, because they have trouble accessing those same tests through the system because of the roadblocks put in the way by legislation and by lack of access to clinicians to get those tests. But I was told when I was a young junior doctor that you only do a test if the result is going to make you change something. If you're just doing a test for the sake of seeing a number, there's no real value in it. So, you don't scan people for if something doesn't hurt because you're not going to have any net effect. It is a little bit more ambiguous now because some of these tests, as we were talking about early, have predictive effects. So we need to start thinking about the values of these tests and how they can be used more effectively. But then we go back to those basics of evidence-based medicine, sensitivity and specificity. If you do a test and the result is positive, is it a real positive or is it a lack of specificity or sensitivity in the test? So you need to know these sort of things as well. So education is important for consumers and clinicians. Access to the right tests, access to COVID tests literally changed the way we treated COVID during the pandemic. But should we be testing for every potential virus and bacteria we come across? Well, no, because some of them, there's nothing we can do about anyway. So I think it's really important to have that regulatory framework, but we also need to have the consumers engage in that, sort of saying, well, why are we doing these tests? We're doing them because there's information there that we believe to be of use and we can't get access to it through the normal system.
Yeah. And at the moment as well, there's no global regulation for most of these things. In some places of the world, it'll be state by state or different jurisdictions. Places like Australia, we tend to do at a national level, but that's confusing as well. So, how many people have gone to the US and picked up a kit for genetics tests that you just can't get here? I think it's a matter of looking at a policy perspective before the regulation as well to understand the drivers, like you said, George. Why do people seek out these things?
And it's interesting because when we've seen the recent data around bulk billing, I mean, the reality is when primary care is no longer free at the point of service, people have to make financial decisions. A $20 test from the supermarket or the chemist is cheaper than the $45 copay at the GP to get a result. People will start making financially based decisions around healthcare, which we've seen in the US is not necessarily the best way to make healthcare decisions.
That's right. All right, George. Well, I think we should take a quick break. And when we come back, we'll be with our special guest of Pulse.
Looking forward to it.
Today, George and I are thrilled to have Dr Alain Labrique join us in the PulsePod studio. Alain is the Director for the Department of Digital Health and Innovation at the World Health Organization, where he is based in Geneva. Alain is an infectious disease and population epidemiologist who has spearheaded groundbreaking research in maternal, neonatal and child health in resource-limited settings. He's won awards, published a heap, and he's well-known and distinguished figure in the realm of digital health and innovation. He's also a self-described digital health and standards geek. Alain, thanks so much for fitting us into your busy schedule. Welcome to the PulsePod studio.
Great to be here. Great to meet you and George. And I've heard so many wonderful things about this podcast. I'm glad to finally be on with you.
I'm glad we can make it happen.
Really looking forward to that global outlook.
So, Alain, I can hardly keep up with your LinkedIn updates. So which country are you in today? Where are you joining us from?
I'm actually in pre-winter Switzerland right now, finally at home after what seems like 4 weeks on the road. A number of global meetings where we've been discussing the future trajectory of digital transformation of health systems, from the UN General Assembly in New York to working with the Ministry of Health in Thailand. I just got back from the Global Health Exhibition in Riyadh, Saudi Arabia. So this space is sleepless and tireless and requires a boundless amount of energy, which, I'm glad to say I still have some of, but I'm glad to be working with an amazing team who makes it possible around the world.
So what's your trick? When you wake up in the morning, how do you remember where you are?
I don't. I literally have to pinch myself and say, which country am I in today? If my wife is there next to me, then I remember that I'm finally home. But the career of global health is one that keeps you on the road. And so it's been a good 25 years of constant travel, because you can't sit behind a desk and help craft the future of global health. You have to be out there in the field, talking to policymakers, talking to people, talking to implementers, and really trying to understand what are the pain points, what are the challenges, and what can you do in the position that you are to help drive things forward. And I think a lot of it is just the privilege of having literally sometimes a bird's eye view on things, where as you travel around and speak to many different people, there's a lot of unique challenges that people are facing based on context, on resourcing, on the politics. But there are also a lot of fundamental similarities. And I think it's those similarities that we're looking to strengthen the resourcing for, and making sure that in 2024, going forward, no country should have to start from scratch. There's so much out there in terms of lessons learned, in terms of best practices, and in terms of technical building blocks. So what can we do as a norms and standards agency, as a convener of multi-stakeholder dialogue here at WHO? What can we do to help bridge some of those knowledge and practice gaps that keep people from making substantial progress? And so it's really exciting. It's a challenge, but we wouldn't do it if it wasn't a barrel of monkeys, as they say. It's a constant fun.
It's obviously a very global role, because this is why you're just your travel itinerary. But WHO appointing a lead for digital health, especially having a global mandate, is a really big deal. You've been there for just over 2 years. Tell us, how did you land yourself in such an esteemed role, and what was your career journey like leading up to that? I'm sure you didn't finish med school thinking I'm going to be traveling around the world managing digital global health.
I actually started life as a molecular biologist. I was studying how yeast cells divide as a way to understand the granular processes for DNA replication. And I got really tired of staring down the barrel end of a microscope. And from there, I went on to study epidemiology and learn about infectious diseases. The thing that really, as someone who was born and raised in Bangladesh, a country that is such an amazing place with such beautiful landscapes and even more beautiful people, the tragedy of maternal and neonatal mortality was something that had been gnawing at me for decades, since my childhood. And the opportunity to study how we could potentially prevent mothers and newborns from dying, I think that really took a lot of my mental energy. And so that's what brought me into public health, right? To try and study at a macroscopic scale what were policies and interventions and programs that could be scaled up to improve the lives of folks on the ground. And as I was working in rural Bangladesh on my doctoral thesis and then as a young assistant professor, we began to see the mobile phone revolution happening. We began to see this leapfrogging of the copper cables that other countries had to install before they were able to speak over long distances. And I remember vividly in the early 2000s, I was running a huge project in northern Bangladesh, and we were just about to put out a tender for carrier pigeons.
Wow.
Because we were so frustrated at not being able to communicate between two of our field sites that were 50 kilometers apart. So I had bought possibly every type of wireless communication device on the market. And, we were still sending messages by courier. And the courier had to jump on a bus, travel 50 kilometers, get the response to that message, come back. And I was thinking, surely we can find something that works better than this. And carrier pigeons was going to be the next option.
They would be faster.
Definitely faster and potentially more reliable.
Good for the environment.
But then we realized, the mobile phone was rapidly making inroads, right? Leveraging fiber optic networks that had been laid in the 1970s. But almost overnight, we went from a country where very few people had the privilege of being connected to now mobile networks covering the entire country of Bangladesh, and the cost and coverage and ownership of devices changing rapidly. And so, that was the sort of harbinger of a future that working out there, reading maternal verbal autopsies and watching how a simple phone call could change the trajectory of a pregnant woman from near death to survival was so powerful. That was the inflection point for me where I said, there's something here. We need to study it. We need to understand better the context and ecosystem of how we go from the serendipity of having a phone in the right place at the right time to seeing how can we build national programs that leverage connectivity, that leverage information communication technologies, that leverage clinical informatics all together in this burgeoning field that you and we have all been a part of called digital health. I returned to Johns Hopkins where we launched a new center for digital health that working closely with WHO and many others in the space, we began to really try to define the parameters of how do we talk about this multidisciplinary space. There's informatics, there's computer science, there's communications, there's public health, and getting all these different cultures and languages into a room to get them to agree on things was a huge hurdle, but we made it. We helped to develop the first ever guidelines for digital health. And then before we knew it, WHO was going through a transformation, and DG Tedros' team decided that it was important for WHO to have a department of digital health. And so when I got the call that they were looking for a director, I thought to myself, there's a lot we can do here at Johns Hopkins, but there's a lot of other exciting stuff that can be done from a global level. And it's not just here in WHO HQ, it's across the 6 regions. There are digital health focal points that are amazing people who have done great things in their life journeys. And all of us together working as a really global team with many people who have had similar trajectories from public health, infectious disease, information technology coming together under this banner of digital health makes for a really powerful group of people to think about how to do this and leverage these tools to change lives.
Yeah, absolutely. So, given what you just said, it's not just you at this global mandate. You're responsible for a team of people who report to you, but then you work with how many countries, how many global field offices? It's a really big role. For those of us who haven't had the pleasure of that sort of mandate, what does your week look like? Is there an average week, like when you're not traveling or when you are traveling? What does it look like? And how would you define the purpose of your role?
20 years ago, one of my mentors told me that the first few years are really tough and you feel super busy, but then things calm down and become normal. And I'm still waiting for that because I think no 2 weeks are exactly alike. I like to say we have 194 bosses. So, as a member state organization, so WHO is the apex agency within the United Nations system for health. So, this UN agency, the World Health Organization, is responsible to serve the 194 member states that give us our mandate to help provide the norms and standards, that is, the science based guidance to countries on what are best practices, what are the technical standards, what does the scientific research evidence suggest are the best investments for governments to make in order to drive benefits in terms of universal health coverage, in terms of reductions in disease and death, and in terms of better health outcomes and wellness for people everywhere. And so, our mandate is really one to serve the entire globe, not one region. But we are what we call a 3-level organization. So we have 6 regional offices representing each of the major population continents around the world. We have about 160 country offices that are led by a WHO representative in that country, and then teams of people who support those offices and work closely with the ministries of health and other ministries to execute the translation of the science-based guidance into practice, right? So it's not just about us sitting back and reviewing science and putting out these big books of guidance, but it's also about how do we move best practices and guidelines into policy and into programs that ministries are running to improve outcomes. And so I think for us, the average week involves technical work. It involves bringing together experts because we may have expertise, but we recognize that expertise is evolving and we need to always be sure we are convening the right people who are from all of these regions who are working on these problems on the ground and making sure we're sourcing the current state of science and state of best practice from those people. And then, we have a lot of meetings where we have to build consensus. Just to note, there's often a criticism of the United Nations or even WHO in terms of the pace at which we sometimes move. And I think that's a fair criticism because, some of these processes are slower than if we were in the corporate environment or maybe in an NGO. But it's because we have to build consensus. It's because we have to bring others along, right? So I think there are many proverbs that abound around, if you want to go fast, go alone. If you want to go far, go together. And I think by building this consensus, by making sure that we're bringing along all the different perspectives and making sure that people are truly on board with the changes that we are discussing, we actually achieve in the long run much more transformative change than short, cheap, activities that really aren't sustainable over time.
Yeah, it's the only way to get things done. I couldn't imagine trying to build a consensus with such a big mandate, but also such a large stakeholder community. So the fact that you've actually produced a huge amount in your 2 years, Alain, which I'm very familiar of, and we'll get into some of them soon, but it's hats off to you and your entire team. Like it's a massive, big undertaking and you've achieved a lot.
So it is very impressive considering also the scope that you're going from, first, second, third world countries with resources, without resources, and balancing that global resource challenge as well, because we have a challenge here in Australia where we are pulling resources from countries who probably need them more than we do just because of the way the national economies work.
It's flattening quite a bit because I was just in a meeting in Berlin a few weeks ago where on the same stage we had the chief information officer of Australia, the chief information officer of the UK, the chief information officer of Brazil and India. And it was quite impressive to see the commonalities in terms of the standards, in terms of the architecture, in terms of the governance that were shared across these very different geographies and political and economic realities. Then there were differences. And, I think there's a great convergence happening now around the world, which we're moving away from an era of what I will call digital experimentation. So where people have been building confidence in the potential of digital as they've seen how digital has transformed other sectors completely. And I don't use this word transformed very lightly, because you look at the financial sector and you see how banking in 2024, anywhere you go in the world, is now fundamentally different from the way it was a decade ago. And that is attributable very, very largely to the digital revolution that has happened around us. And I think these kind of changes require a period of careful experimentation, of cautious, poking the animal to make sure it doesn't bite, and make sure that, we have a robust plan of how we need to move forward. But I think the pandemic was a big wake-up call. The countries that had previously invested in governance, architecture, and ethical and policy frameworks were the ones who were able to pivot very rapidly, leverage a robust local ecosystem of entrepreneurs and developers, because there were standards, there were interoperability backbones in place. They were able to pivot systems and move them to be responsive to the pandemic, whereas countries where those systems didn't exist, where people's trust hadn't been built in those systems, where there were still doubts in the public's mind around confidentiality and data protection and data sharing, that led to a lot of hesitancy and a lot of doubt around whether these systems were truly trustworthy and whether they would achieve the objectives in mind. And so, I think that's sort of the big wake-up call to countries to say, well, if we want to really benefit from the digital revolution in health, we have to start building foundations. The convergence of epiphany and, my taking on this role with sort of the global teams converging around this sort of philosophical approach has really been a fantastic opportunity to move forward in a big way.
On that point, because the Australian health minister during the pandemic was quoted as saying that we managed to do 10 years worth of reform in 10 days as a result of the pandemic. So that ability to do that digital transformation was obviously built very much on the backbone that we'd put in a national network, we'd put in a national shared record, we had done a lot of those sort of things.
George, look at something like telemedicine, right? I mean, that's a great example where telemedicine is not new by any standards. It's been around for more than 50 years, and we have accounts and data going back to when people were doing consultations with clinicians by ham radio in the outback of Australia. And, I think as we look on the global policy landscape, there were many countries where telemedicine was obstructed, not because it wasn't shown to be effective or that there wasn't a strong argument for extending services to people where and when they needed those services, but it was more policy barriers that were in place for a slew of reasons that was preventing telemedicine from being used. Whether it was policies around reimbursements, policies around safety and verification of credentials, et cetera. But these are things that are relatively solvable if we want to. And so the Pandora's box was really opened in a good way during the pandemic, where people got to experience the benefits of telemedicine, right? The parents worried about their kids at 3:00 in the morning having access to a clinician or a nurse using their phones. And I think it's going to be hard to put that genie back in the bottle now that people have had a taste of the convenience and access to health information that telemedicine affords.
I agree. And I know that in a recent speech, you commented about this digital inflection point. So, I mean, whilst the pandemic drove a lot of change, I guess the challenge we now face is in sustaining that rate of change. What's your experience been like around the world and people maintaining that rate of change that we saw in the pandemic?
It's quite phenomenal. I think as we look around the world, we see things like, in India right now, there's a national telemedicine platform that receives between 350 to 500,000 calls a day.
Wow.
Just think about that for a moment, right? And the studies that are emerging now around just that level of functionality reveal that this is not only a health intervention, it's potentially a climate intervention. Because for each of those calls, on average, you're reducing the carbon footprint of a person by about 20 to 25 kilometers, right? That they would otherwise have had to travel to get to a facility to meet with that provider. And so you multiply 20 kilometers by 500,000, that's an awful lot of carbon that we've eliminated from the atmosphere, making telemedicine not just a health intervention, but a climate intervention. But, in places like Rwanda, we have citizens are connected through a universal health platform. In Zanzibar, every single community health worker is now equipped with a piece of technology that allows them to register their clients in a continuous health record. And now you think about that for a minute. A continuous health record, something that many people in the West take for granted as a fundamental given, right? When you go to see your pediatrician, clinician, or specialist doctor, they're able to look at your entire history, usually, and get a sense of where you've been through your health journey. In many parts of the world today, that's such a privilege because you're going to see a doctor and it's as if that's the first doctor you've ever seen. And they have no idea who you are, what you've been through, what your allergies are, what your medical history is. And that's just not okay. So we're really hoping that with some of the work that we're spearheading and we're seeing countries really move forward with, that's going to change fundamentally in the coming years.
Fantastic.
Amazing. Now, one of the things I thought would give you the opportunity, Alain, to spruik some of the great work, the specific stuff that you guys are doing and the Pulse Pod can help promote. So one of the things that I know you guys have been heavily involved in is supporting that capacity building, the foundational work. So what are some of those capacity building initiatives that you're currently focused on? And, what are they doing to help countries accelerate digital health?
When we talk about foundations, human capacity is the first layer of the foundation. Now, we say we can't build skyscrapers without robust foundation. The foundation almost has to be as big and as strong as the height of the skyscraper. And similarly, it's that human capacity that we have to start with and making sure that something you've been involved with, Louise, right? The competency framework is just thinking through what are the basic digital competencies that a health worker in 2024 should have that they may not have needed 10 years ago. And this means it's not just a health challenge, it has to be in the education system as well, starting with elementary school, middle school, high school, university. What are the digital hygiene skills? We teach children to wash their hands, but we need to teach children how to change their passwords, right? To work in an environment that is fundamentally digital. What does it mean to be the custodian of your health record? What does it mean to do basic troubleshooting on technology-based systems? And so I think there's a whole host of digital competencies and competencies to be in a digital environment that need to be applied both pre-service, so before public health or clinical work, but also in service. As technologies are constantly changing, people's skills need to be kept updated. So almost like a CME, continued medical education, we need continued digital education as technology evolves. How do you function with this emerging space of generative AI? And what does a frontline health worker in Kenya need to know about this space? So that's one set of work. We also have been working on a series of trainings for policymakers. We have this thing called the Digital Health Planning National Systems course that has been a collaboration with a number of other partners that has reached now many, many hundreds of policymakers around. I think we just hit our 1,000th policymaker who has been through that curriculum, really training them in not just the shiny objects, but what happens in the background. What's the plumbing and the highway systems that have to be in place for the shiny cars and for whatever runs through the plumbing, the water, the clean water that people benefit from. And so I think we're really excited about training people, providers, policymakers on these foundations. The other thing that we're really, really, really excited about is local production. I'll be a bit provocative here and, say that many have criticized this space for being a form of neocolonialism, the digital colonialism where we have technologies and solutions being imported from the global north and west to the global south. And I think in 2024, we need to push back and we need to understand that capacity has grown tremendously around the world in all hemispheres. And we need to really be equipping local ecosystems, entrepreneurs, governments, and their partners with the tools and the building blocks that they need to start building solutions that are high quality, that are interoperable in country, in Kenya, in Bangladesh, in Chile, right? So that they have systems that are owned and operated locally and that can be expanded, extended as needed based on whatever public health and health priorities that country might have. And so over the last 2 years, we've done these mega workshops in Kigali and Cape Town, and we're just about to do one in December in Nairobi, where we're bringing to the table dozens of countries, the ministries of health and their technical partners who are coming together to learn how to use these building blocks, these standards-based building blocks, whether these are pieces of technology that are reference applications, so-called white-labeled products that they can use to start from, or something that WHO is creating with a lot of partners known as the SMART guidelines, which takes WHO technical content, whether these are the decision support flows for HIV treatment or for antenatal care, and making them available to programmers in a digital technology absorbable format. So rather than having a programmer in a country spending hours and hours going through these giant books and trying to extrapolate what the decision logic should be in programming language, they can actually just go into the WHO Smart Guidelines library and ingest those decision logic algorithms into the software that they're developing, allowing them to focus more on the user experience and the design of the system as opposed to the semantic and syntactic structure of the software. We're really excited about, we're working with companies. At Google, for example, offered thousands of hours of time over the last 2 years to help develop a programming environment for the Android system, which Google is the custodian of, known as Open Health Stack. And that's allowed local entrepreneurs to build standards-based solutions in a much shorter amount of time using this development environment than if they had to build it from scratch. And so we're now able to have interoperability baked into the DNA of tools across the world driven by local entrepreneurs. So that's really, really exciting in terms of building capacity and empowering people around the world.
Absolutely. But can I also just give a shout out to your leadership and people like Graham Grieve and others? If there wasn't an informatician leading this, I'm not sure whether interoperability would be realised to be the important factor that it is. So, to be able to get the tech people, the big companies involved, the policy people all working around a standards agenda, good on you, informaticians.
He's one of our heroes around here, with the work that he and others have done on FHIR. It's truly been a game changer. As much as HTML was for the internet, FHIR has been transformative across income settings. FHIR is a standard that's being used now across the North American hospital systems. And we saw Africa CDC last year come out with a continental recommendation for all systems to be FHIR compliant for national and transnational interoperability. So it's really exciting.
That has been. For Australia in particular, watching one of our success stories go global is great.
Alain, thank you so much for spending so much of your time with us. I said before we pressed record that we could easily talk for 3 hours. Well, 60 minutes has just flown by. So I'll have to work out how I'm going to edit this together. But thank you so much. It's been a wonderful discussion.
Thank you very much again for your time, Alain.
Absolutely. Well, thank you all and have a great morning, evening, afternoon, wherever you are in the world, and look forward to the next time.
Great.
Thanks, Elaine. George, when you can get people like Elaine on your pod, We had such a good chat. We should let the listeners know it went for longer, and there's no way we wanted to edit it all out. So you'll hear from Alain again in another future episode. We just thought we would play you half of the interview.
It's amazing having people like Alain who have such a global perspective of what's happening in healthcare, and not just a first world perspective, but first, second, third world perspective, and a passion for equitable delivery of those care services and how digital can influence that is critical. I first met Alain through you, Louise, at MedInfo, and found him fascinating, and actually had the opportunity to bump into him last year again in Barcelona. So he really is the epitome of well-educated, well-intentioned, passionate people who are transforming the way care is delivered in the world.
Yeah, he's just an all-round great guy, but very knowledgeable. And I'm just so pleased that WHO hired him for that role. As we covered in today's episode, and it'll be in a future one as well, just how much stuff they're doing. Before, WHO really weren't very prominent in the space of digital health. They were, at the meetings, but they didn't really have a prominent voice, and let alone not just the voice, but all of the work that they have contributed to and are leading as well, those documents that they've been putting out that are really designed to work with member states to help make things easier on the ground. It's really impressive.
It really does demonstrate the value of leadership. I mean, people like Alain who take a problem and commit the organisation to solving it.
Yes. Well, you said you're going to Barcelona, so I do believe that a conference season is upon us, George.
Yes, conference time has started. So one of the things about healthcare is that we do lots of conferences, and during COVID, we did many of them virtual, but now they're all becoming back to face. And now we've seen over the last couple of weeks, we've had the big Consumer Electronics Show in Las Vegas, which had a huge health component and even very large aging component. And then we had the JP Morgan one, which is a very much a financial healthcare investor thing. I've never actually attended one, but I have met people who have attended them. They tell me that the conference is great. The parties are even better. So, we need to work our way to one of those events in the near future, Louise.
Yeah, we do. I had a meeting last week with a guy who's based in the UK. So when he suggested the time, I'm like, aren't you going to be asleep at that time? And he's like, oh, no, I'm at JP Morgan's. And he said he's mostly there for everyone he needs to talk to is there. I know someone who got COVID at that before we knew what COVID was, because it's the start of the year. So it was some weird thing happening in China that only the epidemiologists were paying attention to. That lasted for all of 2 weeks?
I was listening to a podcast this morning from The Economist, and they were talking about the upcoming World Economic Forum in Davos. And they was talking how, when the last one, when they had one in 2020, there was a discussion there about this strange virus. And then half the people from Davos came home with COVID as well.
Yes. And they were scary days because, there weren't any vaccinations. People were dying. Very sad. But yes. So, all right, we might come back at a future episode, George, and talk a bit more about conference season.
Yep, in Barcelona for the year. So my first international conference, which I'm looking forward to. This is the Digital Health and Wellness Summit, which is being run by the ECH Alliance in conjunction with Mobile World Congress and 4YFN. Now, 4YFN stands for 4 years from now. It's a major European startup community. And I've attended this conference the last couple of years. It's really quite an interesting event because Australian events, American events, and European events all have their unique characteristics around them. Now, if you want glitz and glamour, you go to the United States. If you want detail and reality, you come to Australia. Europe's sort of halfway in between because all the various European countries are vying for supremacy in this space. And when you look at the European Union, there's some amazing work coming out there. But conferences like this one let you see what's happening in Estonia, what's happening in Romania, what's happening in Portugal, which don't normally make the mainstream press. So I find it quite interesting. So if anyone's heading off to Barcelona for Mobile World Congress, come and visit me at Digital Health and Wellness Summit on the 5th of March.
Oh, that'd be great, George. Okay, great. We look forward to broadcasting stories from what you learn there as well. Okay, and in our final ending up the show, recommendations, George. So is there anything that you would like to recommend to the Pulse Poddies?
AI tools have been giving me so much fun, but I've been throwing journal articles at it. Perplexity I've found to be a really good tool in that regard, and that I can throw articles at it and it gives me summaries, because whilst I love reading scientific articles, sometimes they can go for 20 pages.
Well, I was thinking the Brian Johnson documentary. I'm sure we both would have watched that.
Yes, it's worth watching. It gives you a new insight into what's happening there. And I do note a couple of Singaporeans, Andrea Mayer and Brian Kennedy, who are now at the National University of Singapore, were speaking at that documentary as well. And they gave a more sort of nuanced view on what's happening. The one thing that did come away from that, the focus on N=1 trials, while scientifically I understand downfalls of it, the fact that someone's willing to do this on this scale, I almost take my hat off to him.
Yes. Just a little bit of background. We've talked about Brian Johnson before, but if you're new to the pod and you're like, hey, who the hell is Brian Johnson? So tech guy, made a lot of money. And what he chose to do is to turn his body and his entire lifestyle into a massive experiment, looking at how can he reverse his age, the progression of age. So the idea is if every 12 months, instead of aging at 100%, like 12 months, he's aging at, I think, was it 0.64 or 0.69, something like that.
That was the latest number, yeah.
Yeah, so, he basically gets 3 months for free, but it's quite fascinating. The documentary's on Netflix and it's called Don't Die, The Man Who Wants to Live Forever. And yeah, it is really fascinating. And one of the things that I took away from it, which I wasn't expecting to, is it wasn't so much the science, but the psychology. So he spoke about, this resonated for me, and Ryan as well, we were talking about it for quite a while, that we tend to eat foods based on what our brain says. So our brain goes, that's good for you, you should probably eat that, chomp on an apple. That's not good for you, but hey, bloody hell, it tastes good, so let's have a donut. Or so our brains tend to rule our decisions, good ones and not so good ones. And he was talking about removing the brain altogether from that process and using scientific methodology to be able to listen to what his body needs. So, what do his muscles need? What does your gut need? His point in time. And that determines what he eats and the quantity of food that he eats. And I'd never really thought about the idea of removing my head. I thought that was interesting psychology.
Whilst we all think that science should drive our behaviors, I guess our brains are much more complex than a simple scientific algorithm. The other thing that caught my attention was the fact that he actually used his routine to improve his bonding with his son and his father. And that basically became a family thing. So if at the very least you can use these sort of things to improve family dynamics, that may be part of it. The dynamic between him and his son you saw evolve during the episode was quite interesting.
Yeah. All right. Well, there's a recommendation from George and I. If you check it out and you have opinions, feel free to let George or I know. And if you disagree with us, we're happy to have that as well. So you've got an email address, but also, how to find us on LinkedIn. You guys know.
And there are a whole bunch of articles and books related to that. So we've discussed about this longevity thing before. Some of those books are quite good reading. Some are a bit over the top. But at the end of the day, eat well, exercise, don't smoke, have good social interactions, have good sleep at night, and you probably get 90% of the value there without the 120 supplements and
Yes.
the electroshock to the abdomen. Although I have to admit, even my wife commented on his abs. His abs were pretty impressive.
They're quite impressive. That's right. Okay, well, that's a great note to end the episode on. George, so great to be back with you in the studio. Look forward to our next chat. Thank you. And would you like to read us out, please?
Thank you for listening to Pulse, brought to you by Pulse IT News. Pulse is produced by Ivan Jurek of Octopod Productions. Thanks to Rish Lyon and Emily Mara for contributing to today's episode. Subscribe, follow, and rate Pulse wherever you get your podcasts. You can subscribe to Pulse IT magazine at www.pulseit.news. Send your feedback and questions to pulsepod@pulseit.news. See you in the next couple of weeks.